All right, so 5, 4, 3, 2, 1.
The broadcast is now starting. All attendees are in listen-only mode.
Hello, thank you for joining today's webinar. This is John Howlett with Kaufman Hall, and here with me is Anand Krishnaswamy. Anand is a vice president with Kaufman Hall Physician Strategy Team, focused on helping clients develop clinical and physician alignment strategies and transform their organizations in preparation for their transition to value-based healthcare. He's a frequent speaker at national industry events and has authored numerous articles, including Using Data and Analytics to Improve Clinical and Financial Performance, which is the lead article in the fall 2016 issue of Kaufman Hall Report. Before we get into the presentation, I want to quickly review a few housekeeping items. Whether you're listening through your computer or via the conference line, all attendees will be in listen-only mode for the duration of the webinar. If you're connected through your computer, you'll have the opportunity to send questions to us through the questions pane on your attendee interface. Simply type in your question and click send. At the end of the presentation, we'll answer as many questions as we have time for. If your question is not addressed during Q&A, we'll be sure to follow up with you afterward. Please note that material related to the issues that we'll be covering today, including the presentation and the article I referenced earlier, is accessible within the handouts area of the attendee interface. As a final note, today's webinar is being recorded, and everyone will receive an email within 24 hours with a link to view the recording. Any of your colleagues who registered for the webinar but were not able to attend will also receive a link to the recording. With that, I'll turn it over to Anand.
Thank you, John, and thank you all for joining us here today in the third webinar of the series. We're really excited to continue the discussion on physician compensation at a time that's quite relevant given some of the national discussions around this topic, especially with the final rule expected for MACRA on Medicare traditional fee-for-service in the next coming weeks. In the first webinar, we covered the transition to value and how to effectively engage physicians in your organization towards this evolution and change. In the second webinar, we talked about the current trends impacting physician compensation planning and how best to design and develop a compensation plan for value-based care. Today, the focus will be on the types of measures you will want to consider to improve your provider network performance under value-based care. We'll again spend a few minutes on MACRA, just given its relevance in the current provider payment change arena. We'll then give you an example of how one organization has approached performance incentives in value-based care. And finally, we'll touch on strategies that can improve physician performance and compensation, and ultimately improve your organization's goals for value-based care. As we talked about during our last webinar, physician compensation and performance improvement has really been an evolution over the last quarter century or so, and extending even beyond. And compensation plan really, design planning started with high guarantees and no productivity expectations in the early 90s. And this model really evolved towards the work RVU-based system, which we all are familiar with today. Over time, this included the incremental inclusion of non-productivity-based items, many of which you're all familiar with today, including some of the basic quality measures, whether for patient satisfaction or process of care, as well as other types of compensation related to call coverage, adoption of EMR, et cetera. And that model of the future will continue to evolve. We don't think it's a static model, and we really believe that there will be a greater emphasis placed on those types of triple aim objectives related to quality, to total cost of care management, and patient experience and access. So as the model really continues to build upon the existing compensation framework, which you see here, it's a recognition that there really will be a continued focus on clinical productivity. Again, whether that's measured through work RVUs or in the value-based arena, focusing on items like panel size and member months where appropriate, and also including some recognition of productivity for administrative or research type functions as well. But increasingly, compensation planning and compensation design will need to incorporate elements of value-based care. Again, whether those are focused on quality, process of care, outcomes, service excellence, and access, which can include items like minimum numbers of clinic hours held monthly, or access to next available appointment within 30 days. So this shift of proportional weighting, how much of it is associated with these non-productivity-based items, will really depend on your organization and your own market's readiness. Next slide. Next. So to a large extent, all of your markets are already moving towards value-based compensation today, and we just wanted to spend a few minutes talking about how it's moving towards that in the traditional Medicare payment world for physician compensation, Part B. So this shift in Medicare compensation is really reflective of the changes that are happening in the broader marketplace. So while we're talking here about MACRA and its implications, it really is a carryover effect into what's happening with commercial ACOs, clinically integrated networks, or for those of you that are participating in Medicare Advantage or taking risk for Medicare Advantage or managed Medicaid. So we'll spend a few minutes here talking about what MACRA is, given the expected final rule that's coming by November 1st of this year, and the importance of the performance period measures, which will start in 2017. So MACRA, as you all are aware of, replaces the sustainable growth rate, or DOC6 of years past, and replaces traditional fee-for-service payments with two tracks, the merit-based incentive payment system and the advanced alternative payment models, which includes some of the ACO models, shared savings track 2 and 3, and next-gen ACOs that are full risk type models. But ultimately, the whole concept is that Medicare fee-for-service payments for physicians is building upon the existing legacy programs of meaningful use, PQRS, and value-based payment modifiers that were already pushing physician compensation towards value-based care. And the potential impact of physician compensation will really vary in the outer years, what you see on the right-hand side of this page. The potential impact given your position or your organization's relative performance can potentially range as high as 37% given what the proposed legislation has in place today. Or if you're choosing the advanced alternative payment model track, it's a 5% bonus on top of the risk that your organization will be taking under any of those ACO alternative payment models that I had mentioned. So this, again, is really relevant from a timeline perspective for a couple of reasons. The first is that the performance period is expected to begin on 1/1/2017. And while CMS has recently proposed a pick your pace or select your pace option for how you participate in fee-for-service payments, the reality is we don't expect this to change, or we expect that the drive towards value will continue to be pushed under Medicare. And the other important piece here, too, is the performance period is set for 2017. The payments will start to be impacted in 2019 when we'll extend out into the outer years there as well. So ultimately, this is really critical for your organization to start thinking about what's the appropriate path for your providers and your physicians in your organization, and then also be thinking about, as MACRA lays out certain measures within each of these categories, how does that start to impact how you're thinking about physician compensation planning from a value-based perspective? So there's all sorts of nuances that we don't have time to get into today, and obviously as the final rule is expected by November 1st, there's potential for changes. But we did want to spend a few minutes here today talking about the merit-based incentive payment track, and what that could mean for your organizations and selections of the types of measures that will impact value-based care. So under the MIPS track, there's 4 current program elements, again, building off those legacy programs that I had mentioned. The quality really builds off the PQRS system, the resource utilization, which is really a measure of how you are utilizing resources today, builds off the value-based payment modifier, which uses claims data. The ACI is a reflection of IT, EMR usage, data, and information exchange. And the clinical practice improvement really falls into that service excellence that we had discussed on previous slides, but building upon the types of strategies that physicians are using to keep them engaged and building rapport within the organization. So these programs have all sorts of different types of measures that they can use. There's a lot of flexibility that CMS is proposing within the rules today, whether that's the use of specialty-specific measures for quality, and also population health-based outcome measures to really track the total cost of care performance, whether you're under the resource use track or the population health type quality measures that would fall under that track. There's a lot of potential flexibility in the rules today, and it really varies, but it gives you a sense of how you can be thinking about the types of measures you would want to incorporate into the physician compensation plan design. And we really think this is, again, critical just given that the upside and potential downside impact that this can have down the road. Next slide, please. And this is just an illustration of how we think that compensation could be impacted under the proposed rules today. And ultimately, there's 4 factors that will drive your performance, again, under this illustration of what will happen under MIPS. But it really comes down to your relative performance for the measures that you select under each of those 4 criteria, but relative to your provider peers across the nation. It also will depend on the APM model eligibility. And the nuances there and the subtleties don't mean that you are necessarily putting yourselves into the APM track, but you're thinking about MIPS eligible APMs and how that could potentially impact your provider organization performance. There's also exceptional performance bonuses based on certain thresholds for those of you, again, that are choosing the right metrics and making sure that you're able to optimize and achieve the best possible outcomes relative to the peer group. And the budget neutrality factor is a pretty important item here too. The concept of achieving 37% in the outer years or 19% based on the exceptional performance in the shorter years is really tied out to the fact that this is all relative, and CMS is picking winners and losers under this track. And how people have performed in the past, whether they have chose the right quality measures, whether they're achieving meaningful use, is really determinant of how we think the future will play out, whether physicians really fall as losers or whether they fall out as winners. And because this program is budget neutral, if there's a disproportionate number of quote-unquote losers in this program, in the short run, it effectively creates a multiplier effect that allows those that are quote-unquote winners to really optimize their physician revenue. So again, this is just a quick overview of what's happening in the Medicare world, but it is reflective of what we think is important for you, for your provider organizations to be really thinking about the types of care, or types of measures that you're using under value-based care. So given such changes, how does your organization move towards a model that includes value-based components? And first, we really need to recognize it's an incremental and not a big bang approach, and that it's really thinking about how do we walk before we run in terms of the metric selection, in terms of the plan design. So the first step is to identify and select the metrics that are relevant to your organization and provider mix. And we've provided on this slide kind of the spectrum of measures that you will want to think about that could fit into this non-productivity-based measures. So it ranges from patient experience around age caps, core measures and process of care, to more outcome-based, whether it's readmissions and complications, mortality, length of stay, as well as episodic or disease-specific types of measures, thinking about disease state management, high volume, high utilizer type conditions. And clinical efficiencies will increasingly be important given its impacts on resource utilization and utilization management. So next, given the universe of measures that you'll want to think about, again, ranging across that triple aim of quality outcomes, patient experience, and total cost of care management, you'll want to think about how you're choosing the right measures that align with your hospital's goals and objectives and that are really addressing your core strategies for your organization. And again, in a lot of ways, this ties back to that idea of the triple aim and that your organization is really moving towards improving quality, access, experience, and total cost of care. It really will force you to think about what types of measures will improve clinical efficiency and utilization, as well as those that are more oriented towards the clinical process of care, outcomes, and experience. And that really drives then how you think about evidence-based medicine, the development and implementation of the right clinical pathways and protocols, how you're doing chronic disease management, how you're making sure that you're building in the right program to optimize outcomes, and along the way meeting the right process indicators. And importantly, the selection of these measures need to ensure that you're mixing specialty or even site-specific incentives. So again, thinking about how you develop the right measures, not just for the organization as a whole, but for your primary care physicians, your specialty-specific physicians, your hospital-based physicians, and thinking about how you develop those specific measures along with comprehensive organization, or what I'll call cross-specialty measures, ultimately because you're looking to try and avoid any sort of siloed mentality or siloed approaches to compensation design, because you really need to think about how your organization works as a collective whole versus incentivizing behavior that improves or benefits one versus the collective organization. So the incentives will really need to be drilled down then to the individual physician level, but also managed upwards at the group or network level as well. And this will help to ensure that you're selecting measures and the types of measures that will really help you avoid collective action problems. And I think this is probably most famously illustrated with how the SGR doc fix came about, right? The whole idea of tying Medicare payments to GDP growth effectively resulted in a collective action issue where the individual provider wasn't incentivized to appropriately manage care on their own. And the idea that the greater good then wasn't achieved in terms of being able to manage resources, being able to manage the cost of care delivered. And that applies to your organization on a more micro level, thinking about, again, how are you developing this from a specialty-specific, individual physician-based approach, along with some of the organizational goals so that your behavior changes are really aligned with the organization's overall efforts. And from a leadership perspective, too, when we think about medical directorship or some of the more administrative functionality, making sure that we're developing compensation design plans that are really moving us towards that value-based arena versus trying to maintain us in that fee-for-service world today. And all of this comes down to, in a lot of ways, making sure that you have data that is timely and reliable, that has effectively been risk-adjusted and is appropriately measuring the types of patients that your physician organization is seeing, and that you have enough robust sample size to really validate that the results that you're getting or the measures that you're tracking are appropriate for your physician organization. And we think this is just absolutely imperative to developing the right measures for your organization to track performance. It's about having reliable and accessible data. It's also about being transparent and sharing that data with your physician. In terms of best practices, we think it's really important to get your physicians involved in this process of data gathering, data maintenance, and data reporting, as well as the analytics and tracking. And this really is to ensure that there is physician engagement and buy-in along the way, that they don't view the data and they don't trust the data. And not only are they buying into this and understanding how the data is derived and how the analytics are derived, but they can really serve as the champions then for your change management efforts as an organization as you undertake the compensation plan design. So we wanted to provide then one example of how one organization that participates in ACO risk-type contracts has developed their compensation model. We'll keep this fairly high level in terms of the types of measures and the types of scoring that they develop, but it hopefully will give you an idea of how you can be thinking about a performance scoring rubric or performance chart that really engages and improves performance for your physicians within your organization. So this organization used a variety of measures to track the performance, and it started with looking at what we'll call quality incentives and quality management. And on the next slide, which we'll jump to in a minute, think about the utilization and patient experience aspects, again, of that triple aim that we're working towards. But the concept here, again, was derived for primary care physicians for this organization. But the idea is that you developed quality incentives that are really looking at how do you appropriately look at preventative care, whether it's on screening measures or appropriate utilization of resources when we're thinking about use of imaging for lower back pain, as well as more episodic type measures. And that's thinking about your diabetic care and how are we tracking diabetics who have the right A1Cs or LDL measures that we're looking for, looking at avoidance of antibiotics for acute bronchitis. And the concept here, again, isn't that these are the specific measures that you all should employ for your physician organization, but you should be thinking about what types of incentives and management that you want to have from a preventative or wellness perspective, as well as a chronic disease or episodic disease state type perspective as well. And I think what's critical on this slide here is you look at the time period, the sample scoring, and the allocation isn't so much the time period or that you need to be looking at this on a bi-monthly or a biannual, semi-annual basis, or that the allocations are set at 5 points or 10 points towards the scoring. But it's really this concept that the scoring isn't an all or nothing game, and that there's thresholds that you should be looking at as you develop your scoring rubric. And this is really designed around you need to bring your physicians along, you bring your organization along in an incremental approach. It's not about an approach of having straight winners or losers, but really designing a program that allows physicians to improve along the way and that they're being rewarded for those improvements along the way. And this really ties into your organizational goals of developing a high-performing network. So again, as you think about the types of measures you want to use, it needs to incorporate elements of specialty, primary care, or hospital-based specific measures. It needs to incorporate elements of threshold so that you're allowing your physician organization to improve along the way. So those are just a few of the quality measures that we described. You also will want to think about how you build in resource utilization and patient experience or patient satisfaction. On the bottom there, you can, obviously people have historically used national surveys like Press Ganey or others to think about patient experience and how that could potentially fit into the incentive plan that you design for your physician organization. Utilization management will also be a critical element. Again, it really needs to be thought of on a specialty-specific basis, and here we've given examples of general prescription usage and avoidable ED utilization. And this is really reflective of making sure that your system has the data that is trackable, that is measurable to reflect these types of measures. And another important point that we want to make here too is not just that these are site-specific or specialty-specific, but as you think about resource utilization, you're thinking about the total cost of care management. How are you thinking about, again, that collective action issue and making sure that you're incentivizing your specialists to work alongside your primary care physicians so that they're working in concert versus against each other to manage some of their specialty-specific measures as well as spending per beneficiary or spending per population type measures that apply to your population as a whole under value-based care. So given those types of measures that we've talked about, ranging from quality, resource utilization, experience, we wanted to spend a few minutes talking about what types of strategies you could undertake to improve the performance. Because ultimately this is tied back to the concept of we're talking about physician compensation design that's looking to improve your organization's value-based goals, but it's about developing programs or strategies that help them through that improvement process. So again, you're developing and selecting measures that are not an all or nothing game, that are specialty specific, but also incorporate elements of organizational or collective behavior changes. And you're developing along with strategies that are effectively allowing your physician organization as a whole to improve performance. And this will not only, again, appropriately incentivize the physician compensation or the plan design, but it really allows you to achieve your organization goals around quality of care. So we'll spend a few minutes now talking about clinical variation, which is one strategy or approach to, again, think about how you're incentivizing and developing programs that allow your physicians to really improve and achieve and maximize their compensation, but also allows you to achieve your goals as an organization tied around that triple aim concept. So we propose here an approach to attacking or addressing clinical variation, and it's the recognition that this is a balanced approach. It's about process, it's about people, and it's about utilizing resources that are available in your organization to achieve these results. It's also a recognition that this is not a short-term fix, and that it requires a long-term approach. It requires the sustained approach to really improving performance for your organization. And it ties back with starting with the data collection and upload, making sure that you have the ability to collect data, share data, and utilize data for performance improvement. And it's using that data to identify the right opportunities, identifying areas of improvement on the physician level, on an episodic basis, on a specialty basis. And it's really using that data then to drive those improvement plans, refine those opportunities, validate what you're doing is right, and ultimately executing on those right plans. So in terms of those steps, the data collection is the first. We think the identification of the opportunities for your organization will be critical. Again, thinking about this from a top-down approach, there might be some efforts that you can use to identify opportunities across your whole physician network, whether that's on a quality, patient safety basis, looking at hospital-acquired physicians, PSIs, potentially looking at aggregate discharge transitions of care type plans, but also on an episodic or specialty-specific basis. So thinking about items like sepsis or septicemia, looking at how you deliver musculoskeletal care. Again, thinking back to the back pain example, thinking about how you're appropriately referring patients for surgical care where appropriate versus sending them into that types of care or sites of care where it might not be necessary or avoidable. So we really think the opportunities are driven in a two-pronged approach. And again, the opportunities here are really tied into not just improving physician compensation, but overall improving the quality of care, the value of care that you're delivering into your community today. So we'll just deliver here a couple of examples of how some organizations have looked at it, both from this top-down and bottom-up approach. And one of those ways that we talked about earlier in terms of measures was length of stay. So if you build a compensation plan that starts to look at how are you appropriately incentivizing your physicians on length of stay type measures, you want to have the data, you'll want to have the analytics that allow you to dig into where there might be variability, where there might be variation from a length of stay perspective. So this is an example of how one organization looked at what we call here APDRGs, which again looks at specific conditions or episodes and looks at the severity of illness and builds in some of those risk elements into it, risk adjustment elements into it. But they looked at how they could look across those APDRGs and address length of stay. So again, they're not only improving the individual physician compensation performance, but overall the network performance as a whole. And so they identified 4 episodes based on this top-down approach where they might have opportunities to improve what could be avoidable or unnecessary length of stay variation. And septicemia was at the top there, but you also see renal failure, joints, and some bowel procedures falling into that top look. And from that top-down approach, it really allowed them to dig into the physician level and look at how does this variation apply, whether for septicemia, whether for joints, across individual physicians. What are our opportunities to incentivize physicians appropriately and tie it into where there might be avoidable variation in performance? And again, the data was critical here to be able to identify those opportunities and share it with physicians in a way that allowed them to address what is appropriate variation, but also importantly, what is inappropriate variation that can help them with their performance improvement planning. And so that focuses on what you can consider the more quality-oriented measures. The organization also looked at variation from a cost, or what we've illustrated here, from a charge opportunity basis. The concept here, again, is that we are tying physician performance, not just to quality, or physician compensation and performance, not just to quality measures, patient experience measures, but we increasingly think that resource utilization for the organizations will be critical as we move into total cost of care management, whether that's for Medicare or commercial populations. And this organization evaluated what it looked like on a best practice or internal benchmarking basis of how does it look across our physician organization today. How can we identify individual physicians that may or may not present an opportunity to address variation from a resource utilization standpoint. So the first step, again, was to identify the opportunity and what physicians we would need to sit down with and talk with to identify the opportunity. And it could be tied to length of stay, which results to the charge variation. It could tie into ancillary usage or service usage, whether it's driven by the types of services, OR, et cetera. It can really vary, but it gives you a way of at least digging into what are some ways that you're addressing variation. And again, if you're using measures based on length of stay, if you're using measures based on quality, if you're using measures based on resource utilization, you can effectively use the clinical variation process to drive that improvement for your physician organization. So with that, we think there's some kind of best practices that will be really important for your organization as it relates to these new era metrics. And this concept is really tied to developing physician scorecards and being able to share physician scorecards that are transparent with the data in terms of its gathering, in terms of its usage, in terms of the analytics, and sharing it with your physicians so that they understand how you're collecting data. They're engaged in the process, and they are really supportive of that change to improve performance for your organization. And again, it's tied to items like resource utilization, identifying cost opportunities, looking at length of stay where appropriate. In this example, we've highlighted orthopedic surgeons for knee replacements, and identifying where there's opportunities from length of stay, where it might come from a safety indicator perspective or from a hospital-acquired condition basis, and being able to share that data with them so that they understand not only how they're performing on an individual basis, but how they're performing collectively as a network, how they're performing collectively on a specialty basis in the organization today. And so as you think about the development of your physician compensation plan, it's important to, I think, highlight three elements again that will be critical for your organization. Think about the development of a physician scorecard utilizing the analytics that you have in place today. And it's based on clinical EMR data. It can be based on the claims data as well that you're able to aggregate. Think about how you can use specialty, primary care, or hospital-based specific measures that appropriately incentivize your physician organization and the individual physicians within it. And think about how you can also appropriately use collective measures, whether they're total cost of care or overall outcomes type measures that can ensure that the change management, that the collective efforts and the behavior change that you're doing aren't isolated or don't create inappropriate incentives on that siloed basis, and it's really moving your organization forward as a whole. So we think those are three critical conditions or three critical next steps that your organizations can take relative to next steps. Obviously, as the rules come out from MACRA, it'll be critical for your organization to be thinking about how you can appropriately position your organization to optimize physician compensation under traditional fee-for-service Medicare as well. So with that said,
Great.
John, I'll turn it over to you to provide some additional comments.
Great. Thanks very much, Anand, for that insightful overview. And want to again note to our attendees in our audience, if you have a question you'd like to submit for Anand, please go ahead. Feel free to do so through your attendee interface online. Just go to the questions pane there and submit your question. We'll be happy to entertain as many as we can here today. On that note, Anand, you touched earlier, you commented earlier that really you shouldn't be thinking of performance measures as an all or nothing type of concept, and wanted to see if you might be able to elaborate a little bit further on your experience, what you've seen organizations do around the concept of thresholds and and incremental improvements that can be made within the physician organization. Can you expand on that a little bit, if you would?
Sure, and it's a really important concept that we think, again, it's part of our key takeaways that you all are thinking about. The idea of developing a physician compensation plan that incorporates value-based elements is a reflection that this is an iterative process and it's not a big bang type approach. And so you need to bring along your physicians, your providers along appropriately. We can't just jump in from, okay, today we're not really incorporating outcomes measures, total cost of care measures, and tomorrow we're expecting all of you to be the best of breed in your market today. So the compensation plan then therefore needs to be reflective of selecting measures that are attainable and kind of developing a roadmap along the way for physicians to achieve those measures. And so that's why when we presented that scoring rubric, or the example of best practices of one organization that's taking on risk, there was elements of it that showed, if you're above a certain threshold, you get X number of points. If you're meeting certain thresholds or at the next tier, you're getting certain points, so that you're not creating the punitive compensation plan, but you're creating one that's really trying to effectively bring them along the way and help them optimize performance along the way. So again, we think about when you develop your scoring or your performance rubric, that you're thinking about ways that you're bringing them along that's not punitive, but that actually rewards them for creating improvements from where they are today. And that could look at benchmarking from prior years, so that you're not always comparing to national or regional benchmarks, but you're also looking at internal benchmarks that are reflective of the improvements within your organization. And that really ties to the clinical variation efforts, right? You can think about benchmarking your organization's performance on clinical effectiveness episodically to national benchmarks, or what you're seeing on quality benchmarks nationally, but you can also look at it on an internal basis so that you're tracking performance and appropriately improving performance within your organization.
Great, thanks, Anand. We have another question related to the concept of blinding versus unblinding results when you're talking about sharing data across peers, and the question is simply, when is it appropriate to share the data openly versus blinding it across an organization? Any perspective on that based on what you've seen done in the industry to date?
Yeah, it's a great question. In an example that we use today with the organization that developed its scoring rubric for value-based care, it was not a one-year kind of development period. It's taken them decades to how they brought their physicians along. And the reason I say that is, whether you blind data or not, you really need to first step kind of develop trust and engage your physicians into how they're into this concept of improving performance, right? And so what we've seen is a lot of kind of best practice organizations are actually sharing data and not blinding data, but it's really because their physicians have bought into this concept. They recognize that this is the right thing to do. It's in their collective best interest as an organization. So there might be incremental steps in terms of how you want to blind data at first to get physician buy-in, to get them to understand, why is this so critical and so important for your organization and their own well-being. And then longer term, think about how you start to share that data on an unblinded basis, or really thinking about how you are more openly communicating those issues within your organization. So again, I don't know if you need to take necessarily an all or nothing approach in terms of what's blinded and what's not, but you might want to think about how you take an incremental approach in terms of what's shared with physicians, so you can get that buy-in and trust, and then think about how over time you're sharing more and more data that's transparent, that they're willing to share because they recognize the importance to your organization.
Very good, thank you. We're coming back to the MACRA that you touched on earlier. Can you elaborate there as well a bit on it in terms of how organizations should be viewing physician performance through the MACRA lens at this point, understanding that things are still kind of evolving and taking shape?
Yeah, in terms of what the measures are, there's probably some variation between what the proposed rule looks like today and what the final rule will ultimately say. But the concept of creating flexibility in terms of the measures they're using, the concept of having specialty-specific measures, again, whether it's for orthopedic surgeons, cardiologists, primary care, et cetera, those will be built in, and the concept of being able to track total cost of care per capita spend or Medicare spending per beneficiary to move that collective action or that collective behavior type issue, those will all, we think, will all be still there in the MACRA final rule. So the important things to be thinking about relative to MACRA going forward are, how do you develop the right measures for the specialists, primary care physicians in your organization? How are you thinking about your broader physician compensation plan given the requirements of MACRA? We recognize that there's variation even between what's offered in Medicare Advantage and how they're tracking some of the performance improvement measures on that aggregate basis and how that varies with traditional Medicare. But as an organization, you should start thinking about what are some of the measures you'd want to be using collectively, individually, and how does that align with your overall efforts across populations. One of the important things as we think about MACRA will be how you don't create duplicative or redundant processes, again, for traditional fee-for-service Medicare, Medicare Advantage, and commercial populations, but ultimately thinking about how you develop a collective approach that's tracking measures appropriately across programs and making sure that they're aligned appropriately.
Great, thank you. Another question with regard to frequency, as new metrics and benchmarks are developed and implemented, how frequently should a scorecard be presented, do you feel, both to individual physicians as well as with the larger governing body of physician group? Any perspective with regard to frequency?
Yeah, it's a great question. Again, along with all the other questions, a lot of it ties into the strategy approach that you take. We've seen a lot of organizations that have a committee structure that helps them, that brings along not just the employed physicians, but also the independents, and there's a structure that helps them look at the collective organization as a whole, and that might be done on a monthly basis. And again, you might want to blank some data there, you might not. There might be committee structures that look at it on a specialty-specific basis, so that, whether it's through the medical director or service line type structure, you're looking at the performance measures on a more weekly, bi-weekly basis, so that you're actually looking at how you can engender and incorporate some of the performance improvement plans from that bottom-up approach. So it really ties back, the frequency really ties back to your organizational approach. I think in terms of best practices, we would suggest that you think about the top-down look and having committees that are looking at the physician network performance as a whole, as well as the bottom-up approach where you're looking at some of those measures on a more frequent basis that are more closely oriented to your day-to-day performance and tracking process of care and how you're actually, the clinical pathways and how you're actually implementing care at that specialty, disease state, episodic type level as well.
Great, thank you. I think we are going to wrap then with the Q&A session for today. If we did not have an opportunity to get to your session, to your question, excuse me, we'll be happy to follow up with you afterwards with a different perspective. I want to thank everyone for their participation here this afternoon. Again, the recording of this webinar will be available to you, and we'll send the link out to you to access the recording in the next 24 hours. We also encourage you to go online to kaufmann.com, access the recordings of the first two webinars in this series, as well as a wealth of other educational content and resources you can find there. And then also, if you'll be attending the American Association of Physician Leaders Fall Institute early next month in Arizona, Kaufmann will be representatives there as well. Be happy to meet with you and answer any questions you might have related to the topics that have been covered here today or in the previous webinars, and also provide you with an opportunity to learn more about the total benchmark solution that can feed into the development of a scorecard with regard to the metrics that we've talked about here today. So again, want to thank you for your participation and appreciate your time, and we'll look forward to talking with you again soon.